other hand, people were fascinated by the fact they were able to split up the suture, even in adults. They excite people, but they don't seem to show the dark side of the transverse correction. So this is what I'm going to talk about. I'm not going to show you bright side, because as a practitioner, I experience a lot of a failure. We really have to figure out the reason why we experience the failure. So this is the main topic I'm going to talk about. So instead of exciting you guys, I might frustrate you or disappoint you, but in the meantime, we'll have to figure out what causes the failure, how we can overcome the situation. Because no matter what we do, as a clinical practitioner, if we come up with a success rate of 70%, 80%, that's a good number. But we also have to think about 20, 30% failed people among our patient group. And that's 100% failure for them. So it's not just a number issue, it's something we really have to address with seriousness. So, main question, is success really a success? Is failure really a failure? How we can maximize the success? How to deal with the final failure? And I'm happy to share with you some of the latest research outcomes in my department. First question, is success really a success? Here's 11-year-old girl, class 3, space deficiency of canine. There's no doubt you're gonna need to expand the maxilla. You won't hesitate even 1 second to apply RPE because she is only 11. And you have no doubt that you will be able to gain space at least for the canine. Are you sure of that? So, and then what about the number? Intermolar width was 41 versus 41. How much expansion would we need? About 5 to 6 millimeter. If you think about the canine space, maybe maximum 5 to 6 millimeter would be good enough for us to gain good transverse relation and also space for the canine. And that's something we can easily gain with one-time expansion with RPE. So that's what I did. I see diastema. Not a big deal. She's only 11. We have a space for the canine. So if you consolidate the space, maybe we can barely gain some space for the canine. Of course, because I was a good orthodontist, sincerely, well, I just took the PA view to confirm the transverse expansion even in the basal bone. Corrected the crossbite. What frustrated me was only after 3 months. Like all of you in this room, I'm fascinated by the diastema and everything. In only about 3 months of time, the space is gone. I still have to make a decision whether I have to go for extraction or non-extraction. And well, time flies. I'm obliged to align the mandible, to do something, remove the RPE, and try my best to maintain the transverse dimension with the TP bar. And in the meantime, I noticed another crossbite on her left side. Then I would have to hesitate. I would have to make a decision whether we need a second round expansion or something like that, or we just disregard it. I had a success in my first time expansion and that's it. Why something like this is happening? So this prospective randomized clinical trial, we might be able to reveal some truth. So this is the thing, there are questions whether MARP would secure higher success of maxillary suture separation. So we compared these two groups, 20 versus 20, age matched, sex matched. This is prospective randomized clinical trial. Exactly same amount of expansion. Let's have a look. It's not surprising anymore that we are able to split up the suture using MARP. RPE, regardless of the design, whatever. This is a combination of a mini screw and Hyrax RPE. Now, I want you to focus on the position of the anchor teeth in the basal bone. What is that? First premolar and first molar. Before, after consolidation. The whole time span is only 3 to 4 months. Only 3 to 4 months. Have a careful look at the position of the first premolar and first molar. Right here. Also right here. Right here. Where are they? They are in the bone. During expansion, after consolidation, anchor teeth are in the bone. Okay, that's something we expected. Secondly, what about the regular RPE, regular Hyrax expander? 19-year-old man, we were still able to split up the suture. Yes, there's no doubt about it. Now you have a look at the position of the first premolar and first molar in the bone, especially after consolidation. Have a look at this. First premolar here, first molar here. Compared to the initial, it looks like they are running out of the bone. But the Hyrax was maintained very strongly inside the mouth during the consolidation period. We didn't really remove the RPE. They are still in the mouth, keeping the teeth in position. But teeth were running out of bone. How is this happening? People believe once they split up the suture, they believe if they keep the Hyrax expanded in the mouth, they will keep the basal bone expanded, at least for the consolidation time, which is 3 to 4 months. But in this article, in this study, we figured out that's not the case. Relapse of the basal bone happens first, even during expansion. Second, during consolidation. Why? Because your Hyrax expander is grasping the anchor teeth, which is first premolar and first molar, or second premolar and second molar. And then the anchor teeth are surrounded by periodontal ligament. And periodontal ligament will be subject to bone remodeling in response to any stress from outside. That's what really happened. In RPE group, there was a relapse of the basal bone even during consolidation. And in MARP group, this didn't seem to happen very much. So this is what you see. After only 3 months of consolidation, regardless of the age, even in successful expansion, teeth were running out of bone because basal bone is coming back. Mini screw is needed to secure tooth position within the basal, to unite this anchor teeth, basal bone, and Hyrax expander as one unit. So as a result, in MARP group, you don't seem to have change in the anchor teeth within the basal bone. What about the success rate of the suture separation? There was no difference. So when it comes to success of the suture separation, mini screw doesn't seem to work very much. And then if you care about the basal bone relapse, basically you're gonna need mini screw. And Brazilian group published an article using 8 girls, age ranging from 11 to 14. They did the same thing with a regular Hyrax expander. Even in young individual, they were able to see bony dehiscence, especially around the first premolar. Why is this happening? The same thing. Basal bone is relapsing even during consolidation. So, where's the point? You're gonna need mini screw, not just for success of the maxillary expansion, but just for the stability of the transverse dimension of the basal bone. So if you lose the tooth mini screw on one side in this 26-year-old lady, you can still split up the suture. You can observe the diastema up in the front. But what really happens is that in the failure side, even if it's a single individual, you will see bony dehiscence or washable effect, especially on the failure side. So what is the role of the mini screw? We don't seem to recruit the mini screw for the success of a maxillary expansion. That's a first clinical impression. What do you think about this DJ? Is he working very hard? Are you gonna pay him? I'm not gonna pay him because he's not working. Have a look at his hands. He's not working. If the miniscrew doesn't work for me, I would not recruit miniscrew. So what am I supposed to do? I would not hesitate to use the second round expansion for maximum expansion. This time, I wanted to make sure of a basal bone transverse dimension. I did it. Then still I needed a little more space. So, well, time flies again. I opened up the space with open coil spring, but well, eventually I was able to gain some, decent occlusion at the end of the treatment. It took me a little more than 2 years, and now we are curious, like I told you in the beginning, how much expansion did we need for this particular case? Well, just a little bit of improvement of profile because she didn't have the functional shift. She passed the menarche even before the treatment. And then arch dimension change was just like this. Guess how much expansion we gained? It's 9mm expansion without tipping. Wow, you need a 9mm expansion. Yeah, that's very natural because you expanded 2 times. One time with a regular Hyrex and the another time, second time with the MARP. That's natural. But why did you have to expand the maxilla by as much as 9mm? Because lower intermolar width increased as well, as much as 4mm. Why? So the question is, do you think we can ever make a good guess about approved amount of expansion before the treatment? What is the influencing kind of factor? We would not be able to anticipate how much increase in the intermolar width in the mandible we would gain during the treatment. Why? The question is, why did it increase? Is it growth? I don't think so. Mandible does not really grow like crazy, even during growth peak period. So what really happens is that just because so-called transverse compensation in the beginning, this is what we call transverse compensation. Lower molars are inclined to the lingual side, upper molars are inclined to the buccal side, even without any buccal crossbite, even without any clinical manifestation of transverse deficiency. And then you will put a bracket and you will start leveling alignment with the rectangular wire. Just because there's an angle between the bracket slot and your rectangular wire, as soon as you engage a rectangular wire, you create some moment. Buccal counterclockwise movement in the lower arch, again counterclockwise movement in the upper arch. And as a result, even without your knowledge, you will end up with a buccal crossbite. Only after leveling and alignment, and you will say, I did nothing but leveling alignment. That's what was wrong. You did leveling alignment with rectangular wire, and you induced transverse decompensation, which is exactly why you end up with a buccal crossbite. What does it mean? We would need much more expansion than you think it is when it comes to transverse compensation. So where's the point? Whenever we try maximum expansion, basal bone expansion with RP or MARP, regardless of compliance type, we have to be ready for re-expansion at all times. First, miniscrew has nothing to do with the success rate, it looks like. Second, we need to make sure of basal bone stability. Third, we have to be ready for the re-expansion. Okay, now just because you brought up the idea, I understand I'm gonna need a lot of expansion, maximum expansion. So instead of a 5mm, 6 to 7 or 10mm would be better. Then in order to facilitate the so-called maximum expansion, how about if we just give a bony cut along the midline to facilitate the maxillary expansion? What do you think? Because some people bring up this idea. How we can address this question? This is a suture morphology described by Bertie Nelson. in the orthodontic textbook, but there was a little bit difference. If we go into the suture biology, the suture doesn't seem to be fused even after 15 years. Have a look at this. Facial sutures, especially these facial sutures, remain patent, and we are curious about the controlling factor of these sutures. You will see high interdigitation, but then they are not necessarily fused. What I mean by fusion is ankylosis or synostosis along the suture. What is the controlling factor? What is the regulating factor? First, growth has nothing to do with the suture. Second, mechanical force has nothing to do with the suture fusion. If you get rid of a periosteum, if you scrape a periosteum from the bone surface, it doesn't seem to induce suture fusion. The only thing is a membrane that encapsulates the brain. That has some controlling biochemical instead of biomechanical in regulation. So where's the point? You expand the maxilla and you have no problem expanding the maxilla. A 9-year-old girl, how much? Like 7 or 8 millimeter. And what do you expect in the gap between the two central incisors? 8 millimeter. It's a huge space. Is that going to be filled? You have no doubt there will be bone formation along the line. But what's next? Is it similar to distraction osteogenesis? Is it different, similar, or different? If it's exactly same as distraction osteogenesis, the suture gap will be filled only with bone, and you don't seem to have a second chance of expansion because it's seem ostosed. But to our surprise, the behavior of suture cells, they are different. We don't know exactly. There's tight regulation to maintain the suture. So after bone formation, you will be happy to see there's another suture line right along the midline, as if the suture cells know their fate. I'm the suture cell, I'm supposed to make bone, but on the side, yeah, I'm gonna have to make another suture. So this thing will be possible. And in old time, this is already like more than almost like 20 years ago, back in 2006, 2008, people were worried about insertion of the mini screw along the mid palate because they knew there were cells. And then if you sacrifice it, if you kill the cells, it might affect the growth of the maxilla. And then there was a series of a dog experiment. And the advice was, you better not insert a mini screw along the midline. This is just about mini screw. And what about the osteogenesis along the mini screw? We published a series of articles in APOS Trends in Orthodontics. And we examined two age groups, one young group, the other one aged red group, aged 52 weeks, which is close to early 30s in human. And then we examined bone response on the buccal plate in response to expansion force. And there was just obvious difference between young and old. Have a look at this. You see a very highly wavy surface on the buccal plate in young red group, indicating huge bone formation in response to expansion force, which didn't seem to happen in adult group. But when you look at the suture, this is the PCNA, FGFR2 immunohistochemistry along the suture. And have a careful look at the intensity of the staining. This is the suture line. You will have a lot of brown dots. And PCNA, which indicates proliferating cells, FGFR2, which indicates early differentiation of bone cells, they have almost a similar intensity of the staining regardless of age. So when it comes to bone formation, what cell do you think we'll have to recruit? Instead of relying on buccal plate, we'll have to rely on the huge osteogenic potential of around the suture cells in the mid-palate. So rule number one, you have to consider Marpe when it comes to basal bone expansion for all ages to secure basal bone expansion. Rule number two, You have to also consider transverse decompensation. Don't be fooled by the way they look. Rule number 3, you have to be ready for repeated expansion. And in order to facilitate repeated expansion, I would advise you not to introduce any intramural invasions such as mid-palatal osteotomy, punching, piezo-season, because that way you are obviously killing the cells. If you end up with synostosis, you don't seem to have a second chance of expansion. How do we apply this rule? Here's a 17-year-old girl with obvious crossbite in the front, concave profile. Yes, this is terrible class 3. She passed the menarche, of course. She's going to high school and she doesn't want surgery. She doesn't want surgery. She wants profile change, improvement. Why? Because she's Korean. Koreans are demanding. They want everything for nothing. They want everything. This has nothing to do with the functional shift. One thing that grabbed my attention was intermolar with 42 versus 43. But this reflects some transverse compensation, so we need to, well, this is a pretty much standardized measurement at least in Korea and also on the other side of the world. This is the YTI, Yonsei Transverse Index, that I proposed. When we compare the top and bottom, it was, wow, more than 10 millimeter. So this indicates it's not just a AP problem, but a lot of transverse problem. We have to be ready for that. And when do you think we can address this problem? Because we know suture will get matured. We'll have to address it before it's too late. And then from 3D simulation, you can easily plan some surgery. But if you ever imagine or dream of non-surgical treatment, the first step of the treatment will be definitely transverse correction. That is more than 10 millimeter in dimension. So I did not hesitate to expand the maxilla, level and align the whole thing, and then started leveling alignment, and I was not surprised to see another transverse problem developing on her right side, because I knew that this was in part a result of a transverse decompensation. So then, instead of introducing surgical intervention along the midline, SRP or something like that, just because she was still late teenage, I expanded the maxilla one more time and gained more than 10 millimeter expansion without a lot of tipping of the molars. And in the meantime, like we expected, there was also some increase in intermolar width in the mandible. And now you are no longer surprised at this number. So we were able to make a transition from class 3 to class 1 molar relationship, and more interestingly, we had a profile change in the mid-face, just like that. I was happy to see, but I was also curious about the underlying mechanism. Did we introduce a lot of a backward rotation of the mandible? But there was no such a thing as backward rotation. We tried our best to distalize the lower teeth backward, just like that. But at the same time, we were able to notice a lot of development in the premaxilla area. Development of premaxilla is hard to imagine in late teenagers, but this was possible because we tried our best to recruit, to maximize the osteogenic potential along the midline. There are suture cells. So this is a transition from class 3 to class 1. Not much, well, almost like no change in the mandibular position, but the mandibular teeth has moved backward. There was a development of mid-palate, and there was a transition just like that. So you will appreciate the change in the premaxillary area as if they moved forward. But this is possible only when you have a huge amount of bone formation in the midline, which is which can be enabled only when you maximize the transverse expansion. So this is a transition, initial to final. She's happy, at least short-term retention looks nice. So let me conclude the first part of my presentation just like this. I gave you an idea that many times we would need second expansion or third time expansion because we don't really know how much expansion we're gonna need because of the transverse decompensation. Second question, if we fail, does it really mean failure? Here's a 60-year-old lady with a buccal recession, crossbite, edge bite on one side. So you might want to use your own appliance, but something tells me that we're gonna need, although it was a moderate amount of crowding, we're gonna need some transverse correction. And if we tip the premolar to the buccal side, you will end up with a little more recession. That's what I was worried. So I decided to use an MARPE, a 60-year-old lady. First few weeks, I expanded, didn't see anything in the periodical view. So this is supposed to be failure. So the question is, if we observe something like this, would we have to continue with the same speed? Would we have to continue with a greater speed to be able to produce more force? Or do we have to give up everything? Again, in order to address, find some clues to clinical questions, we really have to figure out what this is all about. And we had to kind of micro CT scan of whole human cadaver sample to really figure out how the suture is maturing along the line. And we examined two suture spots, one mid-paltar suture, the other one pterygomaxillary junction. There are two sutures in the backside of the maxilla. We were going to localize the most prevalent fusion spots so that we can address that particular area with some sort of a minimally invasive surgical procedure. And at the same time, this is a voice from my resident. She was installing the cadaver, and she was surprised to see the fracture of the maxilla. We wanted to see whether we can really break up the suture with heavy force. We were able to do it, and the required force was as big as 300 Newton, which is hard to produce with a regular Hyrex expander. Regular Hyrex expander will be able to produce like a couple kilogram force or up to several kilogram force, but not as much as a 30, 40 kilogram force. So it is impossible for you to produce that much force with regular Hyrex expander, whether it's RPE or MARPE. And more importantly, if you ever do that, you will go to jail. You will go to jail. If you ever fracture, if you ever break the suture, you will go to jail because the fracture is found on the side, not along the midline. And this is very natural because you can find some paper-thin bone on the side. So on the other hand, so we still have to figure out what we'll have to do. If we address highly tortuous suture just like that in a rat model and under some sort of heavy force, we examined what is really happening along the suture line, and instead of fracture point or something, there was no such a thing as a fracture point, fracture area. Instead of that, we observed a lot of osteoclast here and there, indicating some bone remodeling. And you can imagine, have a look at the or serious undercuts, just like the human case, like I showed you. Have a look at the undercuts. Have a look at the undercut. Do you think you can ever imagine splitting up the suture and also have a look at the surface area? This is a huge amount of surface interface between the two maxillary shelves. And then it's not easy to imagine to break it up with heavy force. So So instead of heavy force, I would definitely give them some time for remodeling because I knew that osteoblast and osteoclast will appear to initiate the bone remodeling. Then that's what I did. I waited for 4 weeks and then restarted the expander with the same expander in the same spot. And after a while, we gained diastema, a little bit buccal tipping, but we were able to align the whole maxillary arch without any further development of the buccal recession. Now buccal-lingual relationship is pretty decent. And if you look at the number, there's an increase in the interpremolar width, which is as big as 4.8 millimeter. In intermolar width, the increase was just around 3 millimeter. So I was happy to publish this case report in current Journal of Orthodontist. And based on all the research outcomes, I would have to propose my expansion protocol, especially when it comes to adults over the age of 15, because you know that the maxillary suture will be highly tortuous and wavy, and it's not easy to really separate them with only a heavy force. So after 2 weeks, you'll have to confirm suture separation. If it's separated, you will keep expanding. And then if it doesn't work, you will give them some time of 3 to 4 weeks. You will repeat the same procedure for the next 2 or 3 times. And if it doesn't really work, you finally declare failure, non-separation. Okay, we definitely have to address the non-separation as well. So basically this is remodeling, not fracture. Again, let's take a little more step for darker side. We know that, to be honest with you, we know that RP has a lot of failure. What was your record so far? How about 80% success? How about 70% success? How about 90% success? Are you satisfied with the number? Even if it's 90% success, you still have to address 10% failure. That will ruin your life. Is that correct? How come all of a sudden they highlight? What's that supposed to mean? I was going to talk about dark side. It's not supposed to bright like this. Dim it down, please. So the success rate, again, to our surprise, was only 61%, especially in male, 94% among females. So there was obviously some gender difference. And this number is really frustrating. 61%, even late teenage, early 20s among males. Oh my God, so what am I supposed to do? Was there any gender difference? And this is a part of an article published in the World Federation of Orthodontists. Like I told you, 8 specimens from cadaver, aged 70 to 80, and there were 5 male and 3 female. This is obliteration number. Obliteration number. High peak means high number of obliteration point, ankylosis point. And I don't know, there was a broad spectrum of the suture fusion, broad spectrum. From the front to the back. This is a mid-palatal suture. From the front to the back. We examined like 1,000 slices for a single specimen because we had to. It's a long segment of 7 to 8 centimeter, and each slice is just around 20 micron, 30 micron. So we'll have to end up with 1,000 specimen to really examine all the way from the front to the back. And there was no such thing as gender difference. So we don't know. There was just a little bit of tendency that the male has a little bit high obliteration index than the female. So it has something to do with the gender difference. And obviously, I have to tell you, this is very much different from very famous article. Because the suture fusion is all around the entire suture area, and there's no such a stereotype suture fusion like you see in here. There's no such a thing as a stage D or stage E. One thing is, unless you take a micro CT of a human specimen, you are not able to define suture fusion just like that, because the CBCT is only available for broad imaging. And then in here, they said under the age of 30, stage D and E consist of 90% of the whole specimen, meaning that we are not able to split up the suture in 90% of our samples. Doesn't make sense. We had a success in 90% of our samples in the opposite. So this is not adequate. And we published another article in Seminars on Orthodontics. We're still working on it, but to make sure there obviously is some gender difference, some regulating factor between man and woman. I think this has a lot to do with estrogen. So at least as of now, what we can do is to describe, okay, there's a gender difference. We don't know why. Man has a much less success rate than female. And I think that has something, instead of a bone stiffness, it has something to do with the hormonal regulation. So it is possible that male patient would have higher obliteration than female. So then we still have to think about how to maximize success. Okay, let's give more force. Let's try to recruit bigger mini screw. How about bicortical? How about tricortical? I don't know. Dr. Cha, Jung-Yeol Cha, published an article, very interesting article, using the clinical samples. They recruited 32 patients, and in one group, they used a long mini screw. In the other group, they used a short mini screw. What about the suture separation? Like in the first research outcome that I introduced to you, suture opening did not show any difference between these two groups. And also, in average, I mean, this is ridiculous. Long group had apparently low success rate, but there was no statistical difference between these two groups. So I have to say there's no difference in terms of the success rate of suture separation, even if you use a long mini screw or a short mini screw. That's one thing. And well, I explained this so many times. Unlike our expectation, if we do this finite element study, and when we examine 3 different types of expander, the greatest force distribution was found in tooth-borne RP group. I was expecting something else, but this is what we found. But on the other side, if you turn it upside down, just because there was like I told you, huge side effect on the buccal plate, tooth-borne RP is not readily recommended for expansion in adults, which is why we have to end up with a MARP. So I would compare this to Chinese chopstick or Vietnamese chopstick, which has a junction up on the top. If you want to split up the suture, basically you have to grab the distal part instead of the proximal part to be able to create huge bending moment along the line. There's a lot of people who keep saying you have to place the mini screw, you have to place the Hyrex expander close to the center of resistance, which is not right from my understanding on biomechanics. And in our additional study, we increased the strength of the tooth supporting arm and the stress level went up accordingly. We also increased the dimension of the mini screw in the same finite element model, which didn't seem to make any change. So even if you increase the mini screw dimension, it doesn't seem to be effective. So from now on, I would advise you not to use this thing. What is that? Bicortical? It's oral nasal fistula. One day, patient came to me with the MARPE installed just like that, and I removed that, and the patient says, wow, water is going to my nose. My speed is going up to my nose. Wow, that's a serious medical condition. So it is no use placing the mega-sized screw in the paper-thin area. On the side, it's a paper-thin. Have a look at the mini screw, just like that. Do you think it will be functional or effective? There's no point. And it causes oral or nasal fistula. There's even more crazy guy out there who keeps talking about the oral, nasal, brain penetration to be able to maximize the maxillary separation. Does it make sense? I don't think so. Rule number 5, tooth supporting arms must be sturdy. How can you secure support for mini screw regardless of depth of the palatal vault? We developed this design on the top some years ago to be able to secure the placement of the mini screw regardless of the palatal vault shape, depth, and everything. But that increases the volume of the expander itself. So in order to prevent this from happening, one of the companies in Korea came up with this idea. How about leave the mini screw, some part of the mini screw on top of the bone, but the rest of the mini screw can be supported by some structure that we call piston. So this way, the piston can be movable up and down. And regardless of the length of the mini screw, some part of the mini screw will still remain in the bone. What we need is only 5 to 6 millimeter in the bone. It doesn't have to be 10 millimeter. It doesn't have to be 12, 13 millimeter. So even if we use the 10 millimeter mini screw, the rest of the 5 to 6 millimeter will remain in the bone. That's what we need because they are not supposed to play a central role for maxillary expansion. So this was the idea. Anteroposteriorly shrunk down, small volume, and elevation to facilitate the self-activation of the jack screw with a contrary angle wrench. And the jack screw body can be close to the bottom and can go up depending on the depth of the palatal vault. But then again, regardless of the palatal vault shape, we can still install the mini screw, and no matter what, the rest of the 5 to 6 millimeter mini screw will remain in the bone. And then, well, this is a clever idea to enable self-activation of the jack screw expander. Okay, this is more important now. This is something I didn't really figure out for the past 20 years. Because the companies don't reveal their material property. Based on our research, I constantly, keep nagging on them to produce some expander with a higher strength of the tooth supporting arm rather than mini screw itself. And then recently we figured out that this is the idea. I figured out that one of the companies that I'm working with, they use a very soft stainless steel. So I told them I'm going to need a little bit stronger arm. And then finally they made up this product with a little bit hard type stainless steel, which has a high yield strength, high elastic modulus. And this is where we are, 28-year-old man, success. 27-year-old man, success. 30 man, success. Another 28, success. So, after all, we reached a certain point where we have almost more than 90% success regardless of the gender. Of course, there still may be some gender difference yet, but this number, 97%, is much higher than the previous 79%. So I'm pretty much satisfied with the result. And more recently, before I came here, I had to use the expander in this 57-year-old man just because he didn't have the space for the central incisor to install dental implant. And we gained success. By what? I don't know. I don't think I have produced a much heavier force or something like that. And because we use a reinforced mechanical property on the tooth supporting arm, not necessarily the size of the mini screw. We just use a regular size of mini screw. Just because we are running out of time, I'm not going to share with the video clip. The thing is, basically, using the piston, the insertion procedure is very simple. Because the piston works as a guidance for the installation of the mini screw. It has a length of 5 to 6 millimeters, so it has a pretty much dimension so as to guide your mini screw regardless of the technique you're going to use. So it's simple. So finally, let me propose some of the clinical application of this new device. Just because it's small, installation is easy. You can easily install it in children, adults, regardless of age, regardless of the gender. Now the situation was he was 8-year-old boy who has some situation just like that. If we don't do anything, you'll end up with a serious problem because the canine resorting the root of the lateral incisor. Something has to be done. First thing is a space creation. Second thing is we also have to address the molar relationship. How about distal jet? How about headgear? How about pendulum? How about something else? We expand, and then we install another TP bar to be able to distalize the whole thing, all at the same time. All at the same time. So without patient compliance, we were able to expand the maxilla and gain some space and also improve the molar relationship at the same time. So we saved the canine in this way in less than 10 months of time. And we did not make the profile worse because he had a very, very marginal profile to start with. So this is something that we can do. And also in this 14-year-old man who needs a little more maxillary protraction and also expansion because the posterior crossbite, we want to address both things all at the same time. The front arms can be bent between the central and lateral incisor and canine to be able to expand the maxilla and protract the maxilla all at the same time. This way you don't need the mini plate. This gives you a pure skeletal effect. So this is an example of a clinical application of the newly designed bone expander. We still have to address the last part, which is failure. Failure. Here's a 20-year-old man, class 3. Terrible crowding. We basically have to expand the maxilla. Let me tell you, do you think I'm going to show you success of the maxillary expansion? No, I'm human. I experience failure of this maxillary expansion exactly the same way you experience. Failed. What am I supposed to do? Just because we needed as much as a 10mm expansion, we were obliged to try Marpe. Then we know we're not supposed to give an invasive procedure along the midline to be able to maintain the suture. And at the same time, immediately after leveling alignment and lower arch, then we have to design the second stage surgery. That was terrible. So first thing is we have to make sure of the maximum transverse expansion, whether it's a surgical or non-surgical. It had to be surgical for this particular case, but then again, we still have to address the anteroposterior problem for the procline lower incisor. Then I decide to retract the lower incisor backward by root movement. So this way, I was able to avoid the second stage surgery, aligning the suture. Have a look at that. First stage expansion was done MAR and surgical RP. And then I installed another bone RP to make sure of the suture gap between the two palatal shelves to make sure of the maximum transverse dimension. And after all, we were able to gain this decent occlusion by extracting lateral incisors in the maxilla, lower first premolars. This was possible first because we expanded maxilla maximum. The basal bone expansion was as big as 10mm. And also, if you have a look at the lower incisor, it's retracted not only by tipping, but also root movement, as you see. So as long as you can recruit this kind of a treatment protocol or technique, that you can avoid the second stage surgery or third stage surgery as much as possible. Rule number 6, you will have to know how to manipulate the lower incisor when it comes to serious class 3. Finally, 22-year-old man, terrible crowding, arch length discrepancy was as big as 16 millimeter. And we did diagnose a major transverse problem in this particular case. So I will definitely try to expand the maxilla. I'm a human being. And then, as you see, if you imagine transverse decompensation in the lower arch, if you couple the decompensated lower arch to the initial maxillary model, you will easily see this, leveling alignment will create a very serious transverse problem. That's what really happened in the lower arch. So we would have to address the maxilla ahead of time. I did it. I didn't gain suture separation. Then what am I supposed to do? Then we'll have to move on to extra slow expansion, because this time we entirely have to rely on bone formation on the buccal plate, which is risky and dangerous, but we still have some hope. We really have to slow down the expansion so as to gain some development of the transverse dimension just like that. The reason why I'm telling you is this, even if you fail maxillary expansion, you are not frustrated. Suture separation is just a shortcut to transverse correction, but even if it fails, instead of going directly to the SARP, we can still try something like extra slow expansion, and then maximum amount of extra slow expansion will be as big as 5 to 6 millimeter. And in this particular case, increasing the intermolar width was as big as 7.5 millimeter. The only thing is, it takes time, because we don't want to waste our time. We will definitely expect suture separation, but if it fails, there's still something that we can do. How about the stability? Very fortunately, we didn't experience serious buccal dehiscence or something for the next 4 years. Rule number 7, extra slow expansion. So this is a summarization of my presentation. I think I did my best to answer all of my questions I raised in the beginning of my presentation. Is that correct? No, it's a success, really a success. You have to consider immediate basal bone relapse, be ready for re-expansion. Is failure really a failure? You have to consider intentional interruption of expansion. Then you will expect delayed expansion. How to maximize success? You're not supposed to use bicortical meniscus. I don't know. I have no idea. CBCT cannot detect the suture fusion, so you'll have to give it a try. Instead of that, instead of bicortical screw, I would advise you to strengthen tooth supporting arm as much as possible. And how to deal with the final failure? You'll have to consider manipulation of the upper and lower incisor, and then you will put extra slow expansion or something like that. Was it good enough? Was it good enough? Tonight we're going to have a very luxurious gala dinner at the Rivery Saigon. I really appreciate the organizing committee of VAO for preparing this wonderful event. And I hope you will enjoy the last segment. Thank you very much.